Good evening, everyone, and welcome to Liberty Talks. Born in Iraq in 1988, Emanuel Shapera moved with his family to the UK, where he acquired a beautiful accent. He then moved to the United States, and he's now preparing to become a weight loss surgeon at the University of Missouri, Columbia. He's now joining us to discuss the COVID-19 crisis in our second interview. Emanuel, thank you, and welcome to our show.
Thank you for having me on.
So you've been, so to speak, in the thick of it in the United States, both as a as a citizen and as a medic. So just to kick this off, what's your take again from the perspective of a private citizen, and from the perspective of medic? So, but let's go first with how it's been as a private citizen in the United States and in Missouri during the pandemic and the lockdown and so on and so forth.
Sure. Thank you again for having me on. It's funny that you mentioned that as a private citizen. When you're a young training surgeon, you don't really have much time for a private life, but it's hard to distinguish private from professional life. But I'm by myself. I don't have a family of my own. My parents are in California, so in some ways, I'm fortunate. I don't have to intentionally expose them if I am exposed to, and I don't have to carry home, anything that would harm them in any way. So in some ways, it's both harder and easier as a single person. You're all by yourself. You're in lockdown. You have very little human contact outside of work. But at the same time, I don't have to worry about isolating myself from my family. What's interesting is how how large corporations and businesses consistently throughout human history, cooperate, conspire with larger governments, and unfortunately, it's been no no exception this time around. As a private citizen, I've noticed that small businesses, they suffer. Small restaurants have to shut down, but large businesses like Walmarts and so forth, they survive. You know, I joked with a friend, if you've seen the movie Demolition Man of Sylvester Stallone, they have that hilarious running gag where there was a fast food war and only Taco Bell survives. You know, I was afraid that we'd have a similar situation. I think more than just Taco Bell will survive, but of course, a lot of small businesses owned by families, the middle class, are going to be devastated by this if they haven't already been devastated. And it's just very interesting that you can go to Walmart, you know, which is great from my perspective because it's very convenient, but in the longer run, that's terrible because it's going to destroy my choice. So that's my private perspective. From a professional perspective, as I said, you know, and as you mentioned, I'm a weight loss surgeon. I'm also a general surgeon. I'm in my final years of training as a fellow. So I have my board certification. But anyways, the point is, I don't directly deal with patients with coronavirus, but I am, of course, in the hospital. I'm taking care of patients, some of whom may have been exposed to the coronavirus. And we have to take severe precautions to make sure that they test negative before we can do any kind of surgery. So my professional perspective has changed somewhat. I mean, not perspective, my professional interaction has changed. In the past few months, we weren't allowed to do any kind of operation that wasn't on an emergency basis. Now, as the cases have dropped and as the infection spread has dropped in Missouri, especially central Missouri, we've been permitted to perform very important non-emergent care. And you know, non-emergent care is very important. What people have to understand is when you're in a lockdown, you're shutting down significant amounts of essential services that aren't emergent. You know, they say non-essential travel, non-essential services are shut down, but really there's so many things that are essential that don't have to happen today, but they should happen sooner rather than later. People who need to be screened for colon cancer, for breast cancer, people who have out of control diabetes that need surgeons like myself and my colleagues who need to take care of them to help them to lose weight so they can then, you know, no longer die of a heart attack down the road, whether it's in the next few months, few years. All these things are being delayed, and it's not going to be easy to catch up on that work. And we're already trying to catch up on that work, and it's quite a challenge, but we're up to it.
Yeah, because it's interesting. This actually stems us in two different directions, so I'm going to try to touch on both. So first off is this definition of services being essential, and basically from my perspective as well, everything that was not COVID related became unessential for some reason. And now it's there are increasingly more voices actually raising this problem, this issue that during this period there have been people that haven't screened for you know, cancer or other deadly diseases, and that, you know, the screening that they missed might actually cost them their life. So that's one issue, and I was really curious if this was actually a legitimate issue to think about and to consider, or whether, you know, 3 months is not that much of a time. Even, you know, even in weight loss, because, you know, when people, most people, when you hear weight loss, you think like, yeah, okay, it's something cosmetic. Maybe you can you can live without it, but it's not just cosmetic, right? I mean, it's people's, you know, well-being and health is directly dependent on losing that weight.
Correct. I mean, you have the people that we're dealing with. This is not plastic surgery. We're dealing with people who weigh anywhere from 100 to 260, 270 kilograms, or, you know, up to 600 pounds. And these people have very severe, life-threatening heart and lung disease, and we take care of them by giving them operations in their stomach and their intestine, and it helps them to lose about 50 to 100 kilograms. So they're nowhere near going back to normal weight. They're not, you know, they don't have a beach body, so to say, but we're giving them enough weight loss so that their heart is no longer under constant strain. Their diabetes is under much better control. That's just a small example. As you mentioned, cancer. You know, Medscape released an article quite a while ago, several weeks ago, back when the United States total COVID death rate, I mean, number of COVID-related deaths in the United States was about 30,000. Right now, it's a bit over 100,000. Back when it was about 30,000, they released an article saying at the end of the lockdown, there's going to be an excessive number of cancer-related deaths because of the COVID lockdown, reducing screenings to the tune of about 30,000 extra cancer deaths. So at that point already, you know, we had suffered 30,000 COVID-related mortalities. We were going to get an extra 30,000 COVID-related mortality. And then in addition, psychiatric health, people being locked down, unable to see their loved ones, unable to interact. This is not part of human nature. This is very, very contrary to human nature. And in mid to early April, the United States has already seen more suicides in that year than in the previous 1 to 2 years.
Yes. So yeah, this is a real problem, especially since psychological effects are not maybe immediately apparent. So it might take a while for any psychological side effects to start to manifest themselves. So again, I think that, or this is my perspective, that we'll be dealing with a lot of hidden costs that were completely or mostly ignored just to contend with this, to try to fight this situation, this pandemic. So again, and I think that some of those costs were not probably taken into account very seriously under the pressure of the COVID pandemic.
Correct. And I should clarify, suicide attempts, I should say, not suicides.
Right.
Attempts, which is, again, very strongly correlative with depressed behavior. But the lockdown was done out of desperation because of the trajectory of the case and also very limited information coming out of China and the WHO, which suggested a very high mortality rate. And there is a very high mortality rate. And part of the reason why it suggested a very high mortality rate was because the virus spreads so quickly and is asymptomatic in a large number of patients. But in the people that are symptomatic, they have a very high mortality rate. So before we had screening tests, our case mortality rate was massively overestimated. So based upon the limited knowledge, believing that this was a very fatal disease when caught, and that it spread very rapidly, and that we had no screening tests available at that time, a lockdown seemed to make the most sense, at least to buy some time until we could figure this disease out. Now that we figured this disease out and we know what we're dealing with, we need to change our strategy, because right now we're causing more harm than good with this total lockdown.
Yes. And this is interesting because I believe that, there is an increasingly lack of trust in the scientific community, in the press, and in the politicians, which, well, to be fair, kind of deserve it. And also, I've also noticed that the press has let us down. The scientific community has let us down in good proportion. Especially now we hear of reports on the COVID pandemic using bogus data, and that's a serious situation where we're being told one thing at the beginning of the pandemic and a completely different thing at midway throughout the pandemic, or at the end of the pandemic, or at the end of the lockdown period. So we did have a lot of contradictory information. That we had like medical treatments in March that were shunned, and now they're held as an option, as is the case with hydroxychloroquine, for which Trump got a lot of heat. And now in Romania we had it. It was actually one of the approved or recommended treatments by our medical officials, although in other situations maybe they did not that well. They did have that treatment as an option. So again, this is how do you think the media and the politicians handle this? Do you and again, I'm just talking right now the United States. We're trying to just put a bit of the puzzle here together and see if if we can make some sense of it.
Sure. So first off, let me address the hydroxychloroquine issue.
Yeah.
So there's many things surrounding this. First of all, this drug has been available for many, many years to treat other conditions, mostly inflammatory conditions. Hydroxychloroquine is an anti-inflammatory drug. It works to prevent inflammation in the human body. Part of the reason why COVID is so dangerous is because it makes your immune system attack itself. So by calming down the inflammation, it's possible it can reduce the disease severity. There is some weak data out there that may support that evidence. There's also data whereby if you study hydroxychloroquine in a lab setting, it can destroy the virus. However, there's a lot of data out there as well that's not very well studied, that's not very good quality data, and I'll explain what that means shortly, that basically suggests that hydroxychloroquine, unfortunately, doesn't seem to save lives. Now, the reason why this data is poor is because the hydroxychloroquine was either studied in more severe patients, so they had a greater disease burden, or it wasn't randomized as well, or they didn't study the patient's heart rhythms, because hydroxychloroquine can cause some abnormal heartbeats. But we know that it's safe because we've used it for many, many years. And then another issue is the difference between the United States and other countries in use of hydroxychloroquine. In other countries, except the United States, its use is a no-brainer. It's very cheap. Its risk profile is pretty low. Its benefit profile hasn't really been extensively proven. But at this point of the game, we don't have a silver bullet against the coronavirus. We may as well use this. And at one point, this was first-line therapy for Yale University or Yale Medical Center in treating their patients. Nonetheless, as I said, its benefits are fairly limited, but it's much cheaper to produce in other countries except the United States, which produces almost none of produces very little of its medical equipment and very little of its medical drugs compared to other countries. So partly out of a fear of running out of hydroxychloroquine for other diseases where it has been shown to have benefits, a lot of scientists decided not to recommend its use because they were afraid that it was going to be expended in what they believe to be a futile attempt to treat coronavirus. But the fact of the matter is, if we really wanted to, we could mass produce hydroxychloroquine in the United States, and we could give it to multiple people. We could safely do so and monitor them. And what's more important is the real benefit of hydroxychloroquine is actually as prophylaxis, which means to prevent, which is what Trump was doing actually. He was taking hydroxychloroquine to prevent the coronavirus from manifesting itself. Because as I said, in the lab setting, it's been shown to have virus killing capabilities. It destroys the virus particles. So it makes sense that if you take it as a preventative measure, as soon as the virus tries to enter your system, it'll be destroyed. Once it's in your system and it starts generating massive amounts of inflammation, then it's too late. That's how those studies were studying hydroxychloroquine, when it was too late to give it. Now, there is one other study out there, one more point to make about hydroxychloroquine. There is one study out there that looked at preventing transmission of coronavirus if people were taking hydroxychloroquine. This is a very difficult study to do because you're trying to study people's behaviors, trying to see how they interact with other people, how they spread the virus. They wanted to see if people who had hydroxychloroquine, if they had a lower risk of spreading coronavirus, and they found that there was no lower risk. But again, the study was poorly designed and is not conclusive. Based upon lots of poor quality studies, the FDA basically pulled its emergency authorization. But the thing is, FDA in America doesn't mean that physicians can't give it. It just means that insurance companies won't pay for it usually. Yes. So a lot of this is about insurance companies, what they're willing to pay, which is part of the reason why there's been some criticism with hospitals who are trying to record as many coronavirus cases as possible. When patients come in on a ventilator and they're sick, it's in their financial interests to record that as a coronavirus case because they get significant amounts of reimbursement from the government.
Yes. Yeah, that's a very interesting topic you're opening up here, because there have been increasingly more reports about, hospitals reporting, COVID cases where they were not actually COVID cases, where they actually tested negative. And when I first heard this, I said, well, look, this is too callous. This, although I do know, that, people can be that callous. But now in the face of emerging evidence, and again, it's hard to say whether that evidence is 100% reliable, but now there is quite a lot of it, and a lot of voices mentioning this, that look, we have an issue here. We have an issue with people with hospitals knowing that they're going to receive funding for COVID patients and then listing non-COVID patients as COVID patients, and that is, nearly. I mean, it's not nearly. It's criminal, especially as there are also reports that some non-COVID patients actually got infected in when we are put in the same rooms with COVID patients. And actually, there is there are a lot of dissenting voices already, like Dan Erickson and Artie Masihi from I forgot the name of they have a clinic in California, who actually came out I think a month and a half ago and warned of the effects of prolonging the lockdown period, and also the there was a material by a nurse, Eri Marie Olzevich, I think it's her name, who actually mentioned the exact same thing. She documented this in one of the, if not the most, in the epicenter of COVID cases in New York. So, what do you think about that? How did we come to this? And do you think this would be like a widespread phenomenon, or just something that's limited to a few hospitals, maybe?
You mean the phenomena of over-reporting coronavirus?
Yes.
The thing is, whilst I won't discount callous human behavior, certainly, but the difficult thing of coronavirus is, at least initially, we didn't have the screening tests capable of it, and now we've actually got data that suggests that our current screening methods may be inefficient, or maybe not be good, because we have false negatives. So some patients actually are positive and they test negative. Some patients don't develop the antibody responses. And then the funny thing is, the patients that do develop the antibody responses to coronavirus, the antibodies that we can test, those patients tend to do worse than the patients that don't develop the antibodies, because and that partly makes sense, because it's part of the whole inflammation system. Your body makes antibodies, the protein molecules that target foreign proteins, and we're trying to detect those antibodies. And if you have significant inflammation that's damaging your body, you'll produce more antibodies, at least hypothetically. So what are tests really testing for? They're really testing for if you develop a severe reaction to coronavirus, not if you're getting infected or not. So there is that element. So doctors feel that even in the presence of a negative test, the patient may still have coronavirus, and that may still be the case. So, and as I said initially, we didn't even have any testing capability, or we had very limited testing capabilities. So a lot of this was based upon clinical judgment, the history of the patient. So this phenomena is going to be widespread. I don't know exactly how many, of course, but what it does do is it plays into the idea that coronavirus's mortality rate is probably lower than we think, because this virus is probably more widespread and has infected more people than we like. So the number of people who have died from this virus is actually is smaller than known. And furthermore, we know who's dying more than others. It's the elderly and those who have serious medical problems like diabetes or morbid obesity. So
there has been also talk about, actually, because I remember we discussed about this in our first interview about ventilators. And now there is talk about ventilators actually aggravating the situation of those COVID patients, and that especially since there was a lot of desperate talk about, we don't have enough ventilators, we need to get more. We don't have enough ventilators to put the millions of people that are going to just get infected. And now, as it comes out, it seems that might be an issue. Why do you think that is? Is it because after all, the ventilator is kind of forcing the body to some extent, or what would be a possible explanation for that? Because this is again, it's as was the case with people, doctors and the scientific community and politicians saying, look, the virus is being transmitted through surfaces, you have to clean all the surfaces, and then we find out that the virus doesn't actually seem to be surviving on surfaces. So again, we have like a 180-degree turn on what was initially thought. So what's your take on this ventilator thing? Do you think it's possible for it to have aggravated the situation, at least of some patients?
Well, there's three things to talk about ventilators. First of all, in any lung disease, ventilators can potentially worsen lung mechanics, or lung physiology, rather, I should say. There is something called hyperbaric trauma, or barotrauma, rather. The way the ventilator works is it basically forces air into your lungs and keeps them open. That's positive pressure. Normally, your chest wall, and then especially your muscle called the diaphragm, it pulls down, creates a vacuum in your chest, and it sucks in with negative pressure air into your lungs. So with a ventilator, you have positive pressure. You can actually stretch out the lungs too much and cause damage and trauma. This has been well documented, and the type of disease that coronavirus produces is called acute respiratory distress syndrome. And in acute respiratory distress syndrome, different parts of the lung become flexible and different parts of the lung become very rigid. So what happens is if you put a small amount of air in the lung, many parts of the lung don't inflate and they don't give oxygen to the body. So you have to put a huge amount of pressure, and this can damage some of the more flexible parts of the lung and cause them to rupture potentially.
Right.
So what you do is there's a strategy whereby you give a small amount of air continuously, constantly, and it gradually fills up all the parts of the lung and it keeps it inflated. This causes carbon dioxide to build up, but it allows oxygen to go into the body. This is the kind of breathing mode that ventilators should be using. So ventilators can cause lung damage, but that's probably not the reason why necessarily the coronavirus is worsened with the ventilators. This could be an association rather than cause and effect, i.e. those who are going to die anyways, who have severe disease, they're the ones that need the ventilators, and unfortunately it's not enough, and they end up dying. But the third thing that's important to note is initially the fear of the coronavirus spreading in the air was much greater than it is now. Now we know that the virus by itself doesn't spread in the air. So what that means is if I breathe out and I have coronavirus and the virus particles are in the air and a gust of wind blows them further down the road, scientists believe that virus particle could go into someone else's lungs and we could transmit the virus in that way. That's been shown to not be the case. The virus only transmits in droplets of water. So you sneeze, you cough, you have a wet breath. That's why our opinion on masks changed so many times. At first, it was masks all the time, everywhere. Then it was, well, masks don't work. But really, masks do work. Even a mask as worthless as a cloth mask, it's not entirely worthless, but it's not so great. But what a cloth mask will do is it'll absorb a lot of the water droplets during a sneeze or a cough that carry the virus particles. So initially, we thought that the virus spreads in the air. There are lots of other strategies that the lung needs and can benefit from besides a ventilator, such as a machine called a CPAP or a BiPAP, where they blow air down into your lungs, but without using a ventilator. And a lot of patients, they use this. So basically, doctors were going straight from oxygen by nasal cannula, by tube in the nose, and then straight to ventilator. They were going from mild to severe treatment, and they were skipping the air blowing down the lungs because they were afraid that as the air blows into their face and their nose, it would blow out and spread the virus. So all this positive pressure treatment was not being utilized. Positive pressure ventilation was not being utilized. So instead, they went from nasal cannula oxygen to ventilator, and the idea was that as I said, if you ventilate the lungs too much, you can cause damage to the lungs. So that may have been the reason why overuse of ventilators may have been causing increasing damage. And then finally, that may also account for the reason why they had such a shortage of ventilators. They weren't willing to use any other mode of therapy except an invasive ventilator. Because in a ventilator, the breathing tube goes down into your mouth, into your lungs. And so the air doesn't escape from the mouth. It's between the lungs and the machine. It stays in that circuit. But with positive pressure, what they do is they take a mask and they put it to your face, and it blows air into your face. Some of it should go down your lungs, some of it can go down into your stomach. But the idea is most of it goes into your face and your lungs, but it can blow out elsewhere. And so they were afraid that the virus would spread everywhere.
Will that circulate, right?
What's that?
So that they're afraid that the virus will circulate this way. So
correct.
It will be
actually. They ignored the middle ground therapy. Medicine is all about giving the right therapy to the right disease and not overdoing it.
Yeah. There's also some talk about COVID being, or some findings pointed out that coagulopathy seems to be common in COVID patients. Do you happen to know anything about that?
Sorry, repeat the question again.
It's coagulopathy.
Oh, coagulopathy. Yes.
Yeah.
Basically, when the blood coagulopathy refers to either the blood clotting or becoming too thin to form a blood clot. Usually, in these situations, it's the first one where the blood becomes too thick and clots too easily. And this is a phenomenon that's very common, actually, in patients who have severe inflammation, because the mechanisms that create inflammation in the body are related to the mechanisms that create a blood clot. Because the way the body works is, if you injure yourself, you cut yourself in the skin, the body activates its immune system to try to prevent bacteria from going in. At the same time, it'll also activate blood clotting system so that the blood clots and stops you from bleeding to death. So the two mechanisms go hand in hand, inflammation and blood clotting.
Right. Let's revisit the discussion about how the pandemic manifested itself around the globe, and even in the United States, because I can help to notice that again there are hotspots of COVID-19, and I think that it would be good for us, good for everyone if we kind of figured out why we did those, why did we have those hotspots, and why we still have them, because I mean, is it only the fact that in some areas there are more people than in others, or maybe some areas are more visited or from people from China, by people from China, or had a stronger or more sustained connection with China, or are there any other reasons as well as administrative reasons, for instance, the way the patients were treated, the way the hospitals were run, the way maybe carrying houses were run for all people. So what's your take on that? We still see these hotspots and huge differences between different areas that you know and I think that population numbers don't account for all the cases probably. So what's your perspective on this?
Correct, but population density, I think, is the critical factor, and then population makeup. So the ethnicity of the population, the age of the population, their medical problems, how close their connection is initially to China. So despite the looming trade wars between America and China have significant international travel between the two. There's significant amounts of international travel between the United States and China. And unlike countries like South Korea and Japan, where they have suspicion of China, America, the populace doesn't, and so the local government officials don't. I think that contributes greatly to it. You had the New York Health Commissioner, who was a Democrat, who, as late as the 2nd of February, was warning people not to follow Trump's warnings about the coronavirus at that time, but to go out and celebrate and enjoy the Chinese New Year festivities. So there was that issue going on, for example. There's no way anyone in Japan or South Korea in their right mind would have suggested anything as crazy as that or as dangerous as that. Now, those countries, I'm going a little off topic here, those countries seem to have done very, very well, even though they do have aging populations and they're very, very dense in terms of populations. I think that their relationship between their people and their government, there's a great deal of trust, some of which is justified. They seem to be less partisan than we are in the United States, more traditional based and less about trying to reform their society to some socialist experiment, unlike in the United States, where the political system is torn apart by one group that's trying to bring this country to its knees. But anyways, I betray my political bias there. But going back on topic, I mean, it's very important to have a unified political system. But anyways, the population density, the age of the population, and then also the medical problems. So like you have a country like Sweden, which didn't do any lockdown. It still has the highest both cases per population and death rate per population. But overall, it seems to have not been a complete total disaster. But Sweden is a very Sweden's population is not very dense. They're a very, very large country. They have a few cities, and then otherwise their population density is low. In addition, they have a much healthier population. It's all about, not to be stereotypical, but Sweden eats a lot more fish than the United States does. The United States eats more red meat, and red meat promotes obesity, promotes diabetes and inflammation. Nothing wrong with red meat, as long as you eat it in moderate quantities. But, fish oil is very healthy for you. And in addition, Sweden doesn't have doesn't have as large of a population of individuals of African or Caribbean ancestry, which the United States does have. Sweden doesn't have a 10% African American population like America does. So it's great that Sweden can pat itself on the back and say, look, we had no lockdown and we've done almost okay. But the fact of the matter is the United States has several population densities with large ethnic minorities, and amongst those ethnic minorities and amongst its population, lots of elderly in nursing homes where they're dense, as opposed to being taken care of by the family in a traditional fashion like they would be in Japan or Korea. Their diet is out of control. Everyone's obsessed with sugar and red meat in the United States. No one wants to exercise in the United States, and no one wants to diet in the United States. So all these extremely unhealthy habits that have been building up for many, many years, they're finally manifesting themselves. The people just don't have the health to be able to deal with a disease as severe as COVID. Unlike countries like Japan or South Korea, where you don't see as much obesity, you don't see as much diabetes, or Sweden, where you don't see as much ethnic diversity. The United States has all the high risk factors: an aging population, very dense, so it spreads quickly, and large numbers of African Americans who are more susceptible to coronavirus for some unknown reason.
Right. Now, we're touching on an interesting subject here, and usually when I talk the United States with whomever I talk, I'm also thinking of the United States as really being United States, mainly states with sometimes very, very different policies and very different, even different populations. So would you say that, for instance, this obesity or general health issues would be specific to more to several states or to certain states, or is like a pretty uniform around the entire continental United States?
I think there is a stereotype that states along the beach may have lower obesity rates, just because there's the beach there, so there's a psychological pressure to be beach body ready. But and also the environments that have better access to hospitals.
Sorry.
Sorry, what were you saying? I mean,
No, sorry. Go ahead.
No, whatever. It's not just hospitals, but like cities where they have access to certain amenities that will help them to control their diet for whatever reason, better education. They may have lower obesity rates, but the thing is, you have cities like New York, which is very population dense, and they have a very high rate of diabetes and hypertension, especially in the non-white population. So I think different states are going to have different ethnic and health makeups, but broadly speaking, across the United States, obesity and diabetes is a problem, and most states still have a large ethnic minority component, and those are the individuals that unfortunately are suffering the highest mortality rates in coronavirus. So
since we're speaking of diverse approaches and diverse results, did you notice any differences in how individual states handle this?
Yes,
I know that Governor Mike Parson of Missouri actually was quite reluctant of enforcing a lockdown, and from what I gather, Missouri is faring pretty well overall, right? I mean, most of the districts in Missouri seem to have close to 0 deaths. So did you notice any big differences in how again, the different states of the United States have handled this?
Yes, I mean, so let's talk about my professional view on this, because I'm from a professional as well as a private citizen. Because as you know, I'm training to be a metabolic surgeon, metabolic and weight loss surgery to treat all sorts of problems. And so we have to do a certain number of cases in order to fulfill our training. And some of my colleagues on the East Coast, they haven't had a single operation to deal with metabolic disease in several months. They've only been doing emergency operations. Here in Missouri, I've done at least like 60 operations in the past month and a half that have been non-emergent. And that's been a major difference. I haven't lived in New York, I haven't lived in California, but I know people who have, and life there has been very, very different compared to in Missouri.
Right.
Now, the governors of states that have done well, they should be congratulated. But the fact of the matter is, as much as Governor Parson's done well, he's lucky to be the governor of this state, because there are only 2 major cities in Missouri, and they're both at the very edge and border. You've got Kansas City, which is very close to Kansas State.
Yes.
And then you've got St. Louis.
St. Louis, yeah.
Exactly, which is very close to Illinois. And St. Louis has a very large African-American minority. And most of those individuals, when they do travel, they travel to Illinois rather than to central Missouri. In central Missouri, we have a few small cities like Columbia City, which is where I'm currently at the University of Missouri. Then we have Jefferson City, and then we have Springfield. With the exception of those 3 small cities, each, about 100 to 200,000 people, there isn't really much. There are lots of small towns in Missouri, And small town folk, they're great people. I love them very much and respect them very much. They don't travel too much. Although many of them do suffer from obesity, they're not very severely obese. They do a lot of farm work, which is honest, hard work. So their heart and their lungs are fairly fit. They're not very population dense, and they don't have as many ethnic minorities. This is a very stereotypical of the so-called Bible Belt of the United States, the center of the United States, and so the center of Missouri. So basically, you have a lot of factors that are very favorable against coronavirus spreading. Low population density, fairly young population, hardworking, that they have good heart and lung function, and unfortunately for St. Louis and Kansas City, they're very population dense cities. And those are the cities that have large ethnic minorities, large numbers of African Americans, who unfortunately have a very high COVID mortality rate. Most of the state of Missouri's coronavirus cases and mortality rates are from people who are either from St. Louis or Kansas City.
So would you attribute this, the Missouri situation only to luck or to its, conditions, or again, are there any differences? Because this is important. I think it's the fact that you're able to practice your job,
right,
and that your patients got to get the care they need. It's one important factor. And is that state mandated? I mean, is the state who decides whether these kind of operations can happen or not, or is it a federal decision? So or is it like?
Yeah. So first of all, I think Napoleon Bonaparte said it's better to be lucky than good, or something like that. He says he doesn't look for good generals; he looks for lucky generals. Well, I mean, the thing is, you can make your own luck, and the thing is, no matter how much luck you have, I think. Speaking of other historical figures, let's talk about Niccolo Machiavelli and Aristotle. Life is all about actualizing your potential. Everybody has chances. You have to seize those chances. So in the state of Missouri, I mean, the thing is, you have lots of states like California and New York, where for several decades, the progressive governors have basically forced, unnaturally, engineered a situation where you have very dense cities without any kind of planning, bringing in several uncontrolled, you have uncontrolled immigration. You're not screening for people for their health. You're crowding them in cities. You're stretching thin your resources, and you're not focusing on the health of the current population. It's basically unplanned. It's done in the name of compassion and mercy, but it's basically unplanned. You can't be compassionate and merciful to every single person in the United States. So instead, they just choose to be compassionate and merciful to the people that they can see, to the people that are next door. They don't care about someone dying and suffering on the other side of the world. They can't illegally cross over into a border in the United States.
Yes.
So anyways, just to make false their passion and their compassion to people, these are the results of years and years of bad decision making. Whether you live in a state that's been badly managed, so that it's very dense. Its healthcare system hasn't been carefully nurtured. You've allowed insurance companies and hospital CEOs to go out of control in their power. You've allowed large numbers of ethnic minorities to come in without helping them when they do come in. You just focus on bringing as many as possible just so you can get the votes every 2 to 4 years. These are the consequences. And then also, on the other hand, from an individual standpoint, if you've allowed yourself to divulge in food or indulge in food for years and years, and you become obese and have diabetes, unfortunately, we can't fix that overnight. We can fix it fairly soon with weight loss surgery, but this is what coronavirus is exposing. It's exposing years and years of problems that have been swept under the rug. So there is some luck, but really there's a great element of skill, and skill doesn't come overnight. Skill comes through long periods of planning. So these states like California and New York that have been poorly planned and poorly managed, they don't care about these people. They clearly don't. And their lack of care is now manifesting itself. New York is going bankrupt now, trying to take care of all these patients with coronavirus. Maybe they shouldn't have so heavily taxed and destroyed their businesses. Maybe they should have encouraged the middle class to spread out, not focus on just one city, so they can live like rats, easily controlled by the government.
Yes. Yeah, you make a very good point here, because actually it basically doesn't exist, or I don't think it exists, as it is just probably just the cumulative effect of bad good decisions in
Yes.
time done by collectively, individually, or bad decision if it's decisions if it's bad luck. And again, if someone gets sick and says bad luck, it's most likely something that the result of a number of decisions. Maybe sometimes it's just genetics. I mean, it's but even genetics, we can influence that as well in time. I was just
Yeah.
thinking about there was an article at some point about they've done some studies, I think some genetic studies on the relatives of people that were held in Auschwitz, and they realized that the stress, that the psychological stress, had somehow transferred through their DNA to their kids and their
Yes.
grandkids. So again,
Definitely.
this is
Yeah, and sorry to interrupt you, but in Belgium
yeah.
there was the strike, the I forgot what it's called, but in March of 1945, I believe.
Mm-hmm.
Actually, I apologize, I can't remember exactly. Somewhere between 1944 and 1945, the Dutch went on strike, and the Germans responded by basically cutting off all food supplies. And the Dutch did that in anticipation of the Allies liberating their country, and so there was significant starvation, and a lot of pregnant women who gave birth at that time, they gave birth to premature or small babies. What's interesting to note is that when those babies grew up and had babies of their own, their babies were also small for their size.
Yeah.
So basically, their DNA adapted. It's a process called methylation.
Yes.
Their DNA changed so that the parts of their genes that required lots of food, lots of calories to grow longer and larger were shut down in anticipation of further starvation. But
yeah,
I mean,
it's interesting you should mention that, because I as a layman, I always thought that these changes would take at least generations, that the DNA wouldn't be so quick to react to changes in the environment, and still it's just just one generation to have all these changes is incredible. It's
So I mean, the point is there is luck, but a lot of luck is circumstances that you create or are created by others. And everyone has bad luck and good luck. You just got to make the best of the situation. Now, some people have bad luck and they should be helped, but
so I wanted to touch on one more aspect, which I think is very and I talked about it in the beginning. We are definitely getting increasingly tribalized, and in some respect for good reason. Okay, the issues we are dealing with are real, and this pandemic again has only accentuated, has only just aggravated the whole tribal, the tribes and little, people being in groups and being very adamant about their position. Now, the scientific community was really, really, really affected. I mean, I've already seen issues in the past years where any dissenting opinion, or most dissenting opinions, are very quick to be squashed or silenced. And we've seen during the pandemic that there were really accredited scientists with good records that came with a different narrative, and they were very quickly dismissed as being quacks or conspiracy theorists and wanting people to die. So we're seeing this issue where the scientific community is increasingly dependent on government handouts or on private on private charity, which would be good, but again, it very much depends on the interests being behind the money that these communities are receiving. And there's also this thing of publish or perish, where if you don't get published, then you're basically dead. You're basically somewhere at the outskirts of the scientific community. So what's your take on this? How serious do you think it is, and how do you think things could be solved? How could we just get people, common sense, goodwill people to the table, and have this resolved somehow?
Well, there's a lot of things to discuss there. But yes, scientists have become very partisan lately, and it's a bit of a joke. So I think the most obvious thing has been the whole Black Lives Matter movement in the United States. The thing is, rioting and burning down people's homes and businesses that have no responsibility for any racism or injustice done upon African Americans in this country does no favors for anyone. Any kind of movement that's based upon pure emotion and anger always burns out. A fire will always burn out, but a light that's carefully fueled will last a long time. So what they're doing right now is they're basically exploding in anger. And scientists are extremely partisan. They're extremely spineless. Several doctors' organizations have released statements saying, fears of coronavirus spreading should not stop people from protesting racial injustice. Racial injustice is very important for the health of African Americans and minorities. And also Oregon County released a directive saying that only white people need to wear masks. Non-white people shouldn't need to wear masks because they're afraid that they'll be stopped by police and therefore they'll fear for their lives. I mean, the only reason why you should fear for your life is because you've committed a crime that mandates severe punishment. That's a fact of the matter. George Floyd, I don't know, we still don't know exactly the circumstances except that that it doesn't look like he resisted arrest, but the man who was shot in Atlanta had physically abused his kids, was out on parole because of this insane progressive parole that they were giving to prisoners. Prisoners are freed from prison because of coronavirus, but legal citizens aren't allowed to go and work. This is basically the agenda of the left wing. And scientists have basically been spineless in calling out the hypocrisy and the nonsense of this. In prison, immobilized, prisoners cannot catch and cannot spread coronavirus. Being released out into the public, not only can they physically harm us, not only do they not have the right, they've lost that right based upon their actions. That's why they're in prison, according to our society, but they can now spread the coronavirus. So can you do so also in riots and in protests. But of course, nobody talks about cases rising after a protest or a riot. People only talk about cases rising after Trump launches a rally. So basically, at this point, the scientific community is absolutely immoral. They've lost all kind of moral standing, at least in my opinion. I regularly criticize them on Facebook. I think they're absolutely spineless. Even further is how robotic they've become. Everybody just repeats the same message: stay home, save lives. Stay home, save lives.
Yes.
In the absence of a vaccine or a cure, staying home will not save lives. It just delays the inevitable. But what it does do is it also prolongs the epidemic because it's just slowing it down. The end result is the same. The virus will spread and it will kill whoever it's going to kill. But now there is a point of trying to slow down its spread so that hospitals aren't being overwhelmed. But in the United States, several hospitals are shutting down. Several nurses are losing their jobs. About 1 million healthcare workers have been fired by the end of April because hospitals, they provide the non-emergency, so-called non-essential healthcare. They're unable to generate revenue, so they have to fire their nurses and some doctors. Excuse me. And so, as a consequence, that strategy backfired completely. We haven't improved or protected our health capacity. We've destroyed it in many ways. You know, the whole thing is when you have a war, it's very important to go behind your soldiers and to try to make sure your soldiers are healthy enough. We've had this backward mentality now where we're trying to protect the soldiers at all costs. We have to protect the hospitals and the healthcare workers at all costs, so everybody stay home. But in the process, we're losing the war because the soldiers, they have no war to fight. They're disbanding. They're leaving. That's exactly what happened. I read the newspaper from the United Kingdom, The Telegraph. It's a very good newspaper, and basically there was one commentator who said, "Our strategy of saving the NHS at all costs may seem a little excessive and may have been the wrong one." But then, after that, no one's been commenting to support that because it's blasphemy. How dare you? The NHS is like as a god.
Yeah, it's kind of he has a godlike stature in in the UK.
It's going to take at least a year before a vaccine becomes practical. A year since the start of research, and we've had research for a few months now. But you have governors as stupid as Gavin Newsom say we're going to keep the lockdown going until a vaccine comes out. You will destroy your state long before a vaccine comes out. Yeah. So it's sad. There are strategies that we can do to try to prevent mortality rates, like masks, social distancing, avoid unnecessary events, but we have to go back to work. We have to take care of our lives. So, I mean, yes. Scientists they are so narrow-minded. The same scientists that are basically obsessed about staying home they're not providing an alternative strategy. There's no workable strategy in the long run. You can't just keep saying, stay home, stay home. What's the end goal?
I mean, yeah, you can stay at home indefinitely, in the hopes that, I mean, just stay home and hide. And it's definitely, and what's more, it's upsetting is that these scientists, and not only them, I mean, just also other people as well, they're very aggressive, and there's a lot of vitriol going around in society right now. I mean, this is just exposing, like you're saying, this is exposing, decades of errors and of maybe and things that we swept under the rug, and now they're just coming surfacing, right?
Right. I mean now they want to fix, basically these giant cities that Democrats control, that liberals control, progressives, they're the ones that own the police departments. They're the ones that have basically been allowing African Americans to fester in poverty for years, and now it's Trump's fault. And how are you going to take care of their health? Are you going to let them not wear masks? Are you going to let them riot? This is what's going to kill them by droves and droves.
Yeah, this is also interesting. How the pandemic was a problem for people attending Trump rallies or gun rights rallies, but suddenly once we have like hundreds of thousands of people in the street protesting other things, suddenly the pandemic is not a problem anymore. I mean, the hypocrisy is so evident and so sad, actually. So that's why I was just asking, how how do other people that think, the people that that you trust, think this could be addressed? Because at some point the scientific community will have to somehow sit down and discuss this. Look, because what's going to happen? People are again. I heard a lot of people accusing other people for believing, that kind of stuff or the other kind of stuff, or said conspiracy theory, or, well, who to believe, actually. If the media is most of it is making absurd claims, and the scientific community is making absurd claims, whom are the people supposed to believe? They're logically going to try and find other information sources, right?
Correct. So basically, this abuse of power has allowed people, has forced people to just abandon them. It happened in the media a long time ago. The rise of small media outlets. You and I right now are participating in a media outlet that CNN and MSNBC would hate, because we're just having a discussion truthfully and honestly about things that we're just observing. So the same thing will happen with science. It's already started happening, because scientists have become so politically charged. They mix their politics with their objective observations, and they report what fits their agenda. So now people are no longer believing them. I mean, you cannot be honest. You cannot be any kind of honest doctor with any kind of integrity and say you can't go to work, to a business, because you get coronavirus, but you can go out there and burn it down to save Black lives. Oh, and by the way, you don't need to wear a mask. What? Which one is is the virus politically charged, or is it that you and your opinions are politically charged? So in the presence of this abuse of power and this lack of objectivity, people are abandoning them. So neither scientists nor the ordinary citizen will be scientific in the near future. We are entering an age of lack of science. We will never be this unscientific. I don't think we've ever been this unscientific in human history, because the thing is, even in the past, when we didn't have much mechanistic science, people still respected the scholars, and they respected religious figures who are seen as authorities in science. Now they're seen as a joke, and they are a joke based upon their actions. So this is disastrous for science. It's disastrous for the truth. It's disastrous for everyone, and it's the fault of scientists and the media for trying to worship themselves.
Right. Well, on those happy notes, I think we pretty much covered everything that we needed to cover. Do you have anything else you'd like to to tell our audience, our very small audience for tonight? But we hope that more people will see this material. Anything else you'd like to add for us? Any note on how we should proceed, and or any final words?
Sure. I mean, I think the middle ground is always the best option. So I'm still an advocate of masks. I know a lot of my conservative colleagues hate masks. Masks are very simple to wear. It costs you nothing. You put it on. It stops you from sneezing and spreading the virus in the water droplets. Protects you and your loved ones. And if you're going to a political rally, think about your fellow voter. You don't want them to die. You want them to go out and live and vote.
Right.
So wearing masks and social distancing from anyone else that you don't know, that you don't interact with on a regular basis. And if you have any relatives or any parents that live far away that are sick, call them, check on them, make sure they're doing well. But I would avoid visiting them if you can, to the best of your ability, and until we really can get a better treatment. To shut down everything until we get a treatment is not doable. We can live for a little bit longer just trying to stay away from some people. So the vulnerable people, the elderly, those who have severe diabetes, high blood pressure, they should be kept away from everyone else. Everyone else who's healthy and can afford to get a little sick, which they will from COVID, we need to go out there and work and provide the resources that can take care of the rest of society who aren't as helpful. I mean, isn't this what the liberals want? At the end of the day, they want the strong and the healthy to help the weak and the elderly. Well, then let us go and work.
Thank you. Well, Emanuel, again, thank you for being with us and for shedding some light on the evolution of things in the United States. And I'll definitely hope to have you again in another talk soon.
Thank you. It was my pleasure.